Okay, so welcome to week 8. We're going to go ahead and start with the endocrine system, and then we'll take a quick Kahoot. You guys will go on a break, and then you'll take your quiz when you come back from break, and then we'll go over the remaining chapters. There's a lot of chapters this week, and I know it's a lot of information, so I'm going to try to point out the stuff that I know that you need to know, and then if you guys could try, I'll try to go to one of the exam reviews. I'm pretty sure they're Thursday, Friday, and Saturday this week. I just posted them yesterday, and the PowerPoint of the exam review is attached to the announcement. So if you could go ahead and try to go to one of those exam reviews, it will help you, I promise. And then as always, if you have any questions or if you want to meet with me out of class, just send me a message. So the endocrine system, so the endocrine system is the system in the body that secretes hormones. So hormones are secreted from glands, and there's always a hormone that affects a specific organ. So or the target tissue. So for example, the pancreas secretes insulin, and then the target tissue are the cells in the body that uptake glucose. So you know, when you're talking about endocrine disorders, you're always going to be thinking about what the effect is on the target tissue. And then in addition to endocrine disorders where there's hormones, you can also have inborn errors of metabolism in which you're not able to produce an enzyme that you need to metabolize things normally. And there are a couple of inborn errors of metabolism that you need to be familiar with. One of the more common ones is something called Tay-Sachs. So children that have Tay-Sachs is one of those genetically inherited, so it's an autosomal recessive trait. They have to receive the gene from both of their parents. It's particularly common in the Ashkenazi Jewish population. So this is the Jewish population that's from Eastern Europe, like Russia over there. And they don't have this enzyme, so they're not able to break down fats normally. So they're born normal, and then they progressively develop mental retardation as they continue to grow. So they appear normal until they're about 5 or 6 months old, but then they have this progressive mental retardation and floppiness. There's no cure. All children with Tay-Sachs eventually die, but you do a lot of supportive care in terms of like maybe CPAP, helping them breathe, etc. So most people of Eastern European Jewish descent know their Tay-Sachs carrier status, and they can do genetic testing before they try to have babies, but there are still some children that are born with Tay-Sachs. And another, so Tay-Sachs is they're missing this enzyme, but another sort of problem that you can be born with is congenital hypothyroidism. So this is going to be hypothyroidism of the newborn. So they're born without the ability to produce the thyroid hormone that they need. And this one is important to note because if hypothyroidism goes untreated, then it can lead to mental retardation. But if they get treatment early, then they can have a normal life and they can develop normally. So you've probably talked about hypothyroidism in your med surg class. So think of hypo as like down. So when they're hypothyrotic, they're sleepy, they're kind of limp, floppy. They tend to be cold with dry skin. They can have chronic constipation. Sometimes they snore a lot because they don't have good airway control. So if you have a baby that has these symptoms, I mean, obviously you would be concerned, but one of the things that you need to be concerned about is that they have congenital hypothyroidism. So they do test for hypothyroidism in all 50 states. So there should be a newborn screen, but screens are not 100% accurate, and not all babies are born in the hospital. And then in contrast to congenital or newborn hypothyroidism, sometimes people develop hypothyroidism later in life. So then you would have juvenile hypothyroidism, and the symptoms are going to be similar to congenital, where they're sleepy, they're tired, maybe they have weight gain, cold, dry skin, brittle hair. So the treatment for both congenital and juvenile is to replace the missing hormones. So they're going to end up taking Synthroid, which is replace the fact that they're not able to produce the thyroid hormone that they need. So it is mandatory to screen. So babies that are born in the hospitals in the United States, they're all screened for hypothyroidism. But like I said, not all babies are born in the hospital. Screening tests are not 100% accurate. And then there's also the juvenile where they develop it as teenagers. So the treatment is to give the synthetic thyroid hormone. It's commonly called Synthroid. Um, so and you need to make sure that the parents know that it's once they're diagnosed, it's a lifelong illness. So they'll be taking Synthroid throughout their life, and they'll need to have their hormone levels checked throughout their life to make sure that the medication dose that they're on is correct. So sometimes they get too much of the medication. So in those cases, if they were taking too much of the medication, they would have symptoms very similar to hyperthyroidism. So if they're taking too much, you would expect the opposite of the symptoms of the primary disease. So they would have a high heart rate, irritability, weight loss, sweating. They might have a hard time breathing. And then if they're too little, you're going to expect them to be sleepy, constipated. Everything slows down when it's not enough of the thyroid medication. Everything kind of speeds up if it's too much. Does anyone have any questions about thyroidism or hypothyroidism? No. So there is another endocrine disorder that you'll see in pediatrics. Some people get confused because it says the word diabetes. So diabetes insipidus is different than diabetes mellitus. So they're not at all the same condition. It can be hereditary, or it can be acquired. If it's acquired, it's usually after a head injury. It's the posterior pituitary is inside the skull. So when there's increased intracranial pressure, it can change the function of the posterior pituitary gland, and then it can cause diabetes insipidus. So when they have diabetes insipidus, they have uncontrolled diuresis. So this is going to be massive urine output. They're just pee like crazy. And they can become dehydrated, and it's very, very dilute urine. So they're just kind of peeing all their water out. So diabetes insipidus, there's a hormone called antidiuretic hormone, ADH. So when they have diabetes insipidus, they don't produce enough ADH. So because of that, they have that massive urine output. So, and that is different than, of course, diabetes mellitus. So I'm sure you guys have all heard of diabetes mellitus, but I would love it if someone would tell me, what is diabetes mellitus? What's the main problem if you have diabetes mellitus? What does the patient not produce?
Enough insulin.
Insulin. Okay. So when they have diabetes mellitus, they don't have enough insulin. So then do they end up with a high blood sugar or a low blood sugar?
Low. High.
High. So when they have diabetes mellitus, they have hyperglycemia. And they're not able to move that glucose into their cells that they need for energy. So then they end up breaking down their fat instead of using glucose or carbohydrates as energy. So they end up with glucose spilling into the urine. So one of the things that you see when someone is being diagnosed, or before they've been diagnosed with diabetes mellitus, is they have a lot of extra blood sugar, and that spills into their urine. And sometimes that can cause them to have high urine output. So when they're unable to move the glucose into their cells, glucose is normally your cell's energy source. When they're unable to do that, then they break down fat as their energy source, and that leads to a buildup of ketones. So they end up with ketonuria, and they can also end up with something called diabetic ketoacidosis. So when they're not able to move their glucose into the cells, they break down fat instead of glucose, and that leads to complications. So long-term, the treatment for diabetes mellitus, especially diabetes mellitus type 1, is the one where they don't produce their insulin. Is it can cause blindness, it can cause circulatory problems, kidney disease, neuropathy. So all of these things are avoidable if they take the right amount of insulin to manage their disease. But if it's not treated appropriately, then they're going to end up developing these complications throughout their life. So we break down, diabetes in terms of type 1 versus type 2 as the main things that we think about in pediatrics. So type 1, they don't produce insulin. And then type 2, this is going to be your overweight kids. You see this more often in people that are obese, and it also has a lot of what we call insulin resistance. So their cells don't respond to the insulin. So they produce insulin, but either they don't produce enough for their body mass because they tend to be obese, or their cells don't have the same sensitivity to the insulin and they're not able to move the sugar into their cells like they should. So the main thing that you check when you're working somebody up for diabetes is their blood sugar. So the diagnostic criteria, fasting glucose over 126 after no intake for 8 hours. So really fasting. And then just be able to recognize, type 1 tends to be an autoimmune condition, also maybe a genetic predisposition that tends to run in families. And in this situation, their pancreas isn't producing the insulin that they need. And then type 2 that's the bigger kids tend to be obese, sedentary lifestyle, and they do produce insulin, but they don't produce enough, or they have insulin resistance. So the type 1 diabetes is the most common metabolic disorder. And you see it, you'll see it kind of when kids are going through growth spurts between age 5 and 7, and then 11 to 13. It can be difficult to manage because kids are growing. They have hormone fluctuations. Sometimes it's hard. Kids have to poke themselves. It's a difficult disease for them to take care of at home. They tend to be non-compliant because they don't want to be different than other kids. So there's a lot of reasons from a developmental standpoint that it can be hard to manage in pediatrics. So this is your classic triad of symptoms, they always call it. So the polydipsia, polyuria, and polyphagia. Can anyone tell me what polydipsia means?
Always thirsty.
Always thirsty. Very, very good. And polyuria is a lot of urine output. And then what does polyphagia mean?
Always hungry. Always
hungry. Very nice. So, they can have this triad of symptoms and then also be weak. Girls might have more like yeast infections, their skin becomes dry. Sometimes they can have these symptoms for a while before they're diagnosed. And sometimes they're not diagnosed until they develop what they call diabetic ketoacidosis, or DKA. And that's when they've gone so long, they've broken down so much fat instead of using insulin or glucose as their energy source, that they have this buildup of ketones in their body. So you would expect them to have hyperglycemia because they're not able to move their glucose into their cells. And then they end up breaking down their protein and fat as energy, so they have decreased protein stores. Sometimes kids will have this honeymoon period where they actually get better soon after they're diagnosed. It can be somewhat difficult to really get them on their right insulin schedule because, sometimes they're diagnosed when they're still producing some insulin, and sometimes they have like a rebound where they're a little bit better and then they get worse again. So sometimes parents will think that they don't really have diabetes and they'll kind of be in the state of denial. So you just need to make sure that parents know that sometimes there is a honeymoon phase, and it doesn't mean that they don't have diabetes. It's still a lifelong illness, and they're going to need close monitoring, and they're still going to need to be on insulin. And this is just going to be like a random glucose is drawn at any point in time, but fasting, you need to make sure it's more than 8 hours. And you look at, for diabetes mellitus, it's a fasting glucose greater than 126. Sometimes you will also do a hemoglobin A1C. You probably talked about this in your med-surg class. This looks at what your glucose level has been over the past 3 months. So once they're diagnosed, if you want to see how tightly they've been controlled, it would be normal to draw a hemoglobin A1C. And then this glucose tolerance test, they do this also. They also do this when women or teenagers are pregnant to see if they have gestational diabetes. So diabetic ketoacidosis is probably in the short term the most dangerous thing that can happen with diabetes. It's also called diabetic coma. So this is sometimes kids aren't diagnosed until they go into DKA. They come in obtunded, not a normal neurological exam, with very high ketones, tend to have fruity breath, very rapid respiratory rate, very weak with like cerebral edema. So they have like this obtunded state. So you would expect ketones in their urine. They're very acidotic. It's a ketoacidosis. It's one of the more common things that you'll kind of remind parents to look for is this fruity smelling breath. Ketones kind of smell fruity. So they can have nausea and altered level of consciousness. And there's a wide range of how sick they are. You can die from this. So the ranges are really from mild to severe. So the general goals that you're going to have as a nurse when you're taking care of somebody that has diabetes is that they have normal growth and development as much as possible. So they can still play sports, but they're going to need some additional education, because exercise also influences your insulin response. So when you exercise, a lot of time your blood sugar goes down. So they need to make sure that they eat before they exercise, that they have snacks on hand or money to buy food if they play on a sports team. So you just need like a little bit of extra education and support. They should be able to do the other things that kids do their age, but they need like extra guidance to make sure that they're safe. So always being culturally sensitive. Some insulin products are made from pork based. So then you would have to, if you were an Orthodox Jew or a conservative Jew, you might not want to take that. So then you would have to find a different insulin that wasn't pork based. So just making sure that you're being culturally sensitive when you're helping a family where the child has diabetes. So I mentioned this previously. There's lots of different reasons why diabetes is harder to manage in kids than in adults. And their growth it comes in spurts. So they're going to have like varying insulin needs as their growth changes. Also, it's very common for kids to really want to eat junk food and cakes and ice cream and fast food. And none of that is good for kids. But it's really important when they have diabetes that they be avoiding those things and that you're making appropriate adjustments to their insulin based on their carbohydrate intake. And then adolescents, particularly, I'm sure you guys have all known adolescents. It can be really hard for adolescents. They don't want to be different than their peers. They have the intellectual ability to understand the disease, but it doesn't really fit in well with the adolescent lifestyle. They want to go out to eat with their friends. Maybe they're experimenting with alcohol. All of those things can make it harder for them to manage their blood sugar. So when you're helping parents, they're going to be part of a multidisciplinary team. They're probably going to have a primary endocrinologist and a primary care doctor, and then a nurse that's helping them manage their insulin. So a well-balanced diet is best. And then very, very targeting their insulin administration, usually to their carbohydrate intake, and then regular exercise is important, but trying to make sure that they don't like go out and like climb a mountain when they don't normally climb mountains, because when they exercise, their blood sugar can go down. So consistent regular exercise is a lot easier to manage their blood sugar than going through these sporadic exercises. So there's a lot that goes in to teaching parents. The kids, starting around like 7, 8, they can start participating in like checking their own blood sugar level. You want them involved in their disease management, so then when they get older, they're able to inject their own insulin. You need to make sure they have a plan for when they travel, that they know how to get in touch with their doctor if they have any problems. Sometimes they have strips at home to check for glucose and ketones in their urine. They're at higher risk of infection. You need to make sure that they're monitoring their skin and looking at their feet, and that they know that it's a lifelong illness that's going to need a lot of follow-up with their doctor. So that we've talked about this, the main goal when you're doing with diabetes is that they have as normal growth and development as possible, and they get their insulin needs to match their nutrition intake so that they grow and develop normally. If you can get kids to eat fiber, it's always good, but particularly with diabetes, it helps control blood glucose levels. They tend to have lower levels because it takes longer for food to get absorbed in the GI tract when you have fiber in there, so they don't tend to have these glucose spikes. So it slows the rate of absorption. So it helps them have like a more steady blood sugar level when they eat fiber. So parents need to be taught how to read labels carefully. Just because something says dietetic doesn't mean that it's really low in sugar. They should really be able to look at the ingredient list and see the carbohydrates and see how many carbohydrates the serving is, and also to make sure they know how much is in a serving. A lot of kids are managed with insulin based on their carbohydrate intake. They call it carb counting. So the parents are really going to have to get good, and then the kids as they get older at reading food labels. So you're going to be teaching both the parents and the children on how to administer insulin. So I'm not really sure for LPNs where you guys are going to practice. Do LPNs give insulin? Yeah. Okay. So you do need to know how to be able to administer insulin. This picture here shows you want to make sure that it's going, under the skin, but not into the muscle. So you want to give it into this subcutaneous area. And you want to make sure that the kids, you're teaching them early. By the time they're like 7, 8 years old, they can start injecting their own insulin. I wouldn't necessarily have them draw it up, but they can start poking themselves. And then you need to make sure that you're rotating the site. They can develop scar tissue if you always give the insulin in the same area. This picture here shows you where on the body you're going to have this deposits, the subcutaneous areas. So these are places where you could give the insulin shots. And then there are 2 insulin that you can mix together. What are the 2 insulins that can go in the same syringe? You guys know?
Yes.
They're regular
and NPH.
NPH. Okay. So you should be able to talk about, you put your air in first and then you draw it. And so you should be able to recognize, what your process is for drawing up regular and NPH insulin. And then, so different insulins have different peak onset times. So which one is faster, like regular or NPH? Which one works quicker?
I think regular.
Regular.
So the NPH is a longer acting. Humalog or Lispro is really fast, and something like Glargine is really slow. So you should, if you ever have a patient that's on insulin, you should recognize what the peak onset is. So if you gave someone insulin, like they're in the hospital, you gave them their morning insulin and their breakfast didn't come, you would need to make sure that you gave them something to eat so that their blood sugar didn't drop. So whenever you're giving insulin, you need to be able to know when the peak onset is for the type of insulin that you're giving, so that you can make sure they have something to eat if their food doesn't come, and that you're monitoring them in that appropriate time frame. So insulin shock is going to be, hypoglycemia, usually because they got too much insulin. Or it could be they exercise too much in combination with receiving insulin at the same time. So this is obviously very dangerous also. So hyperglycemia long-term causes a lot of complications, but you can go into coma, you can die from hypoglycemia. So the opposite of like getting too much insulin is also very dangerous. So kids, in general, they have more risk factors than adults. They're still growing. They have immature body organs. Their needs for insulin are irregular because of their growth and what they eat. So they're at higher risk for adults. So one of the main things that you might see is sometimes they feel jittery or they're sweating a lot. Those can be signs of hypoglycemia. And then like later signs are going to be some of your CNS symptoms. So you need to make sure that parents are aware that it can happen. Usually you want them to have like a readily available sugar source. Sometimes it's like putting frosting on their gums. If they're still awake and alert, you would have them drink like some juice or eat some graham crackers, but they need to be able to recognize what hypoglycemia presents like and have like a plan, a sugar source available to give them if they develop signs of hypoglycemia. So, the immediate thing is going to be giving them something that has glucose, something like juice. And then they do have glucagon, which is like an injectable. It's an IM injectable form of glucose. Sometimes they'll prescribe that to have at home, but usually they teach the parents to recognize the symptoms and have a plan of what they have at home to give them if they have signs of hypoglycemia. Something that you'll sometimes see in kids that are managed with insulin is something that's called this Somogyi phenomenon. So this is a rebound hyperglycemia. So this is going to be kids that wake up, their first morning blood sugar is high, but it's not because they didn't get enough insulin. So your body has reserves in your liver of glucose. So if you develop hypoglycemia in the middle of the night, your body responds by releasing glucagon from your liver, which will increase your blood sugar. So it's a rebound hyperglycemia in the sense that they probably get too much insulin, probably NPH at night, that drops their blood sugar in the middle of the night, and then their liver responds and they wake up with a high blood sugar. So it's sometimes when they wake up with that early morning blood sugar and it's high, like the knee-jerk response is to give them more insulin, but that's not what they need. They need more information to see if they're having like a low blood sugar in the middle of the night, and then they're having this rebound hyperglycemia in the morning. And that's different than what's called dawn syndrome, which is where they're not getting enough insulin and they wake up with hypoglycemia or hyperglycemia in the morning. So we don't talk much about type 2 diabetes in pediatrics because it's not very common, but this is going to be obesity, sedentary lifestyle, a high fat diet. Usually in kids, they start with diet and exercise. They don't go straight to medications. In cases that are, pretty bad or refractory or not responding to diet and exercise, they would start with oral medications. They don't normally do insulin for type 2 diabetes in kids. So do you guys have any questions about any of that? Nope. Seeing some head shakes. We're going to do a quick Kahoot and then you guys will go on your break. Let me see here. Let me log into the Kahoot for you. So what occurs as a result of inadequate insulin secretion? Protein synthesis is increased. Increased fat breakdown leads to ketonuria. Rapid conversion of carbohydrates to glucose, or serum glucose levels are markedly decreased. All right, so good. You don't have the insulin, so you can't bring the glucose into your cells. So then your body breaks down fat as an energy source, and that leads to ketonuria, or a buildup of ketones. So a child receives a combination of regular and NPH insulin at 8 a.m. At 8:45, breakfast has not been delivered. As the nurse, are you going to give the patient a snack? Are you going to give the patient more insulin? Are you going to ambulate the patient? Or are you going to tell the charge nurse? Yeah, you're going to give the patient a snack. You need to make sure that they have something for their insulin to work on. You need to give them a glucose source. So a mother reports that her 4-month-old is lethargic, sleeps 18 hours a day, and snores. What do you suspect? Hypothyroidism, type 1 diabetes, Tay-Sachs disease, or hyperthyroidism? Well, very good. That's going to be your hypothyroidism. They don't have enough of the thyroid hormone, so they're really sleepy. Everything is slowed down. Sometimes they snore because they have bad muscle tone. So after a closed head injury, the child begins to excrete copious amounts of pale urine and has a drop in blood pressure. Why? Is that hypothyroidism, diabetes mellitus, hyperthyroidism, or diabetes insipidus? Very good. That's your diabetes insipidus. Nice job. So which chromosomes are associated with type 1 diabetes? 6 and 7, 12, 20, or all of the above? So it is all of the above. One thing I want to point out is trisomy 21 is not. So Down syndrome, trisomy 21 has a lot of associated health problems, but not specifically type 1 diabetes. So which process does the nurse explain the endocrine system is primarily responsible for controlling? Stress, growth and maturation, reproduction, or all of the above? Good. So it is involved in all of the above. So like your cortisol is released in times of stress, which is one of the hormones. One of the things that it's not responsible for is sexual identity. So just to kind of know that, you develop, but how you develop and what gender you're born with or assigned at birth is, that's all related to your endocrine system and your hormones, but that doesn't necessarily indicate your sexual identity. Which symptoms does the nurse recognize as an indication of synthroid overdose? Tachycardia, diaphoresis, irritability, or all of the above? Yeah, so all of the above. So Synthroid overdose is going to be very similar to hyperthyroidism. So there's too much thyroid hormone, everything's revved up, you're higher heart rate, higher respiratory rate, you sweat more, you're hot, you're irritable. So this is an indication if they have hypothyroidism that they're taking too much of their medication. It's the wrong dose. So which comment made school age indicates that he needs more teaching about diabetes, mellitus, and exercise. Sometimes I skip my breakfast when I have a game in the morning. I make sure I have emergency money when I have soccer practice. I play soccer games that are scheduled after dinner, or I carry a hard piece of candy with me in case I start to feel shaky. Yeah, so just always remember that sometimes your blood sugar drops when you exercise too much. So skipping breakfast is going to be a problem if you're going to go play soccer and you have diabetes, because this can make your blood sugar low. So that's the thing that you would be worried about. All right, good job, everyone. So go ahead, it's 9:40. Go ahead and take a 10-minute break and come back at 9:50. And when you come back at 9:50, your quiz will be up. So I'll see you guys in 10 minutes.
Professor. Hello? Mm-mm.
Miss Rebecca. Professor?
She took her earpiece off. She can't hear
Oh,
y'all.
she did.
Okay, as you come back, go ahead and flip your camera back on so I know that you're here and I can see you.
Professor, I have a question. I looked in the announcements, but I don't see the exam review or the times in my announcements.
Let me take a look. Thank you for saying something.
All right, thank you.
Yeah. Mm. Yeah, so it looks like I only posted it in one class, so let me do it right now for you guys. I apologize. Okay, so I just posted it. Hopefully you can see the review times and the PowerPoint at the bottom. Doing a quick review here. Making sure people's cameras are on. All right,
Professor,
Sia. Yeah, go ahead.
I have a question. So
Sure, go
I
ahead.
sent you a message the other day. I can't remember who class I said I was gonna attend, but I was supposed to, I'm in your original Monday class.
Okay.
Work today, but it's tomorrow, so I just joined for today, but my quiz is not available.
Okay, tell me your name.
Yashika Drummer.
Yashika Drummer. All right, Yashika, give me just 1 second.
Okay.
Let me go into your thing here. It'll take me a second.
Professor, did we start the quiz or no?
Give me 1 second. I'd rather everyone start at the same time. Let me get
I'm sorry, I
Yashika's
had
quiz open.
already.
Oh, you
I
already
saw-
started?
Yeah,
That's
because
fine.
it was quiet, so I thought everybody was doing the quiz.
No, yeah, that's totally fine. Don't worry about it. Go ahead and take it. I am gonna turn on Yashika's quiz here really quick though, so just 1
Okay.
second. But if you already started it, don't worry about it. Just stay on though. No one log off after because we'll go right back into the material.
Okay, sorry.
No, you're fine. I didn't clarify, so don't worry about it. Quiz 5. So Yashika, if you can go ahead and log back in and let me know if you see it.
Okay. Yes, ma'am.
Okay, so if you already started, great. If not, everyone go ahead and take their quiz. And then when you're done, just go ahead and stay on and we'll get started with the rest of the material for this week.
Progress.
Professor, something was wrong with my connection. Did you say start the quiz?
Sorry, I was on mute. Yeah, you can start.
Okay. So back on mute. So here, come put my phone on mute.
Professor, Professor, my computer is completely frozen. Oh my God.
Is that SATA whose computer is?
Hello?
Yeah, whose computer is frozen?
My computer, yeah, my computer is frozen right now. I can't do anything.
Okay.
What in the world?
Is that SATA?
Yes, my computer is completely frozen.
Okay, SATA. So just after class, send me an email and we'll set up a time for you to take the quiz. Okay. Don't go ahead and log out of your computer and then log back in and rejoin the
Okay.
class once your computer's working.
All right. What? What?
Recording in progress.
Okay, so with all the computer problems, et cetera, we're not gonna be able to get restarted probably till 10:25. So for those of you that are done, go ahead and come back at 10:25. We'll start at 10:25. By then, the people that had computer issues should be done. So everyone come back at 10:25.
Oh, God, this is it.
So I apologize. Let me look at one thing here, guys. We'll get started in just a second. I know that it's a couple minutes past our start time. Okay, so hopefully everyone can see my screen with the genital urinary conditions on there. So we're going to go ahead and get started here. So this is one of the 4 chapters that we're talking about this week. And I think I've mentioned this before. Let me make sure that I'm sharing my screen appropriately. Okay, so one of the things that we always need to worry about when we're talking about pediatrics is sexual abuse. So one of the systems where we will see sexual, or yeah, one of the systems where we'll see sexual abuse is in the genital urinary system. So, you know, sometimes we'll see kids that have frequent urinary tract infections, or that have problems with frequent or excessive masturbation, or they have nightmares that are out of the ordinary, etc. So just to kind of be aware, you know, you always have to be on the lookout for sexual abuse in children, and you might see it in the genital urinary system. So there's several different tests that might be ordered when we're talking about evaluating the genital urinary system. We're talking about, you know, from the urethra all the way up to the kidneys. So there's a pretty large area, and there's several different tests that they might do to evaluate the system. There are some key terms that you need to know. So dysuria is painful urination. Frequency is having to go a lot. Urgency is really feeling like you have to go. Like when you have, I don't know if any of you have had a urinary tract infection, like you really feel like if you don't go to the bathroom, you're going to pee your pants. Nocturia is wetting the bed at night, and uresis is daytime bedwetting. Polyuria is a lot of urine, and oliguria is a decreased urine output. So you should definitely know these terms and then be able to think about what might cause them and use them when you're describing a child's problems with the genital urinary system. We're going to talk specifically about some problems that boys might have. So if you have a narrowing of the foreskin, so obviously this is going to be something that you see in children that are not circumcised. Sometimes you can't pull the foreskin back down over the shaft of the penis. So this can lead to something called paraphimosis, which is an emergency. So if you can't get the foreskin back down, it can cause decreased blood flow to the tip of the penis, and that can be an emergency. So, you know, if parents, sometimes they'll like pull the foreskin down when they're cleaning the penis, and then they forget to bring it back down. So, so this is just something, you know, to be aware of. You need to make sure that you do good education and training for parents if their child is uncircumcised, that they're able to pull it down after they clean, and if for some reason it gets stuck in a position, that they know they need to seek medical care. And then 2 other problems that you might see related to the penis of boys are epispadias and hypospadias. And both of these have to do with the position of the urethra. So instead of being at the middle of the tip of the penis, in epispadias, it's up above, and hypospadias, it's down below. There's a range of problems with the urethra. So they normally repair it surgically, not right when they're newborns, because usually they're able to get their urine out okay. It just kind of spatters or doesn't come out in a normal stream. So they normally do it before they're 18 months old, so before their potty training. And they recommend that parents do not circumcise, because they'll use the foreskin to do the urethra repair. So epispadias and hypospadias, these are just the pictures. This is, you know, normally you would expect the urethra to drain out here. So in epispadias, it's on top, and in hypospadias, it's on the bottom instead of being in the middle. And this kind of causes the urine to kind of dribble out or sputter out. It doesn't have a normal urinary flow. So those are some problems that are specific to boys. All children of all genders can have what's called exstrophy of the bladder. So the abdominal wall, the muscle wall in the lower part of the abdomen is missing. So the bladder is exposed. So it's just open to room air. So, you know, it's something that has to be repaired right away. They don't don't eat, they don't have any sort of like a normal newborn period. They go to surgery very early in life. You're going to place a diaper under them because the urine is kind of leak around. And you need to make sure that they're always on their back. You can't like put any pressure on that bladder. And they are going to go to surgery right away within the first 48 hours of birth. So obstructive uropathy just kind of refers to anything within the urinary tract. Like I said, the urinary tract goes from the tip of the penis all the way up to the kidneys. So when they have obstructive uropathy, there's an obstruction somewhere in that system. So it could be like a kidney stone, a tumor, some narrowing scar tissue. So there's several different things that can cause an obstructive uropathy, and they might have to do some diagnostic imaging tests to kind of see where the obstruction is. Children can obviously get urinary tract infections. Urinary tract infections are more common in girls than they are in boys. And that has to do with the length of your urethra. So the urethra of the boy goes all the way through the penis to the tip of the penis. So it's further away from their anus and the different bacteria that can live on their skin in their genital area. So the most common bacteria is E. coli. If for some reason, they take like bubble baths or they're wearing tight fitting underwear, it kind of is like set up to get like an E. coli in the urethra. And it's also important to note that normally your urine is pretty acidic, and if for some reason it's alkaline, then you're more likely to get a urinary tract infection. So you can recommend things like that they drink cranberry juice, that will make their urine more acidic, and that might help with the urinary tract infections. So they can get a urinary tract infection at any age. If they're an infant, they usually need to be hospitalized and get IV antibiotics. Older kids can usually be treated at home with oral antibiotics. So you need to make sure that parents kind of have a good idea about like making sure they're getting adequate fluids, that they're flushing their bladder and their urine out, and they have information about giving the antibiotics at home. So the best thing for urinary tract infections is to prevent UTIs. So you want to make sure that you're doing a good job of cleaning that perineum after each diaper change. You always want to wipe from front to back. You want to avoid bubble baths because that can be irritating. And then children should ideally pee after they take a bath. They can get water into their urethra and there could be bacteria and stuff. So if they could pee after they take a bath, that's best. And cotton underwear is better than the synthetic nylon underwear because it breathes more, they get more air, and ideally loose fitting. And stasis, or not really having urine move through the system, is also a setup for urinary tract infections. So making sure they're not getting dehydrated and that they're peeing normally. So that's the urinary tract infections. This is usually something kind of related to hygiene, and I don't want to give the impression that it's bad. A lot of kids get urinary tract infections, but they're usually preventable, and a lot of nursing education and anticipatory guidance can kind of help prevent kids from getting urinary tract infections. Something that is not related to hygiene at all, or any sort of home routine, is something called nephrotic syndrome. So nephrotic syndrome is like an umbrella term that describes a number of different conditions that cause there to be too much protein in the urine. So when kids have nephrotic syndrome, they have kind of like leaky tubules where they spill a lot of their protein or albumin in their urine. It's usually an autoimmune problem, and they typically give steroids when they have a nephrotic syndrome flare up. So they'll give steroids, and that will kind of help tamper down the problem. So some general sort of symptoms that you'll see, their kidneys aren't working normally. They're not able to filter normally. So you'll see some edema and weight gain. Maybe they won't feel very good. They have a lot of protein in the urine is the main thing. And they're also somewhat prone to infection. in combination with the disease and also the fact that they take steroids on a regular basis, which tampers down their immune system. So the primary treatment is going to be steroids. And then they come in the hospital. Sometimes they'll give them albumin followed by Lasix to kind of help move the excess fluid off. They also tend to be on a low salt diet to kind of help prevent the edema. And they might be on a fluid restricted diet. These kids, sometimes they have to come into the hospital on a pretty regular basis. So they might need a primary nurse or primary nursing team that knows the family and the child. So it's a lot of supportive care. There's no cure for nephrotic syndrome. Like I said, usually it's treated with steroids. You need to make sure that when they're immune compromised, if they're taking steroids, you alter their vaccine therapy. They're going to need strict eyes and nose, and sometimes they need protective isolation, meaning they're in isolation because they're at risk for infection, not because they have something that could make somebody else sick. Does anyone have any questions about nephrotic syndrome? So a condition that kids can develop is something called acute glomerulonephritis, which is going to be a problem with your kidneys following a strep throat infection or maybe a group A hemolytic strep skin infection, but is usually a strep throat infection that later causes this autoimmune reaction where their kidneys get attacked. So it usually involves both kidneys, and there's a wide range of symptoms. It can be from mild to severe, but they have like decreased urine output, fluid overload, hypertension. They tend to be in the hospital in their acute phase, but almost all children recover without any long-term problems.
Can I just ask that glomerule, that is literally the filtering system of the kidney, right? Like that, it's
Mhm.
not filtering correctly, correct?
Yeah, you're correct. Yes.
Okay.
Yes. Kids can also develop tumors on their kidneys. So Wilms tumor or a nephroblastoma is a kidney tumor. The main thing that you need to know about Wilms tumor is they usually take the kidney out with the effective tumor. And when you're caring for somebody that's been diagnosed with Wilms tumor, you need to make sure that you don't palpate the abdomen because you could cause damage to the tumor, rupture the tumor, cause problems. So they usually have a sign above the bed that say you don't do any abdominal palpation. And then post-surgically, they're going to have the normal post-abdominal surgery precautions, and then they're going to get their chemotherapy regimen after the tumor has been removed. So they'll do surgery, radiation, and chemo. They do remove the entire kidney. And then you're going to do your routine postoperative care. In terms of pediatrics, is one of the most common solid tumors. So hydrocele is just an excessive fluid around the testicles, so the testicles look swollen. So sometimes it happens right after birth, and that fluid kind of reabsorbs. If it's still there around 1 year, then they normally do surgery to drain that fluid out. So this is one of these words that I have a very hard time pronouncing. Cryptorchidism is failure of the testes to descend. So when you're in utero, the testes develop inside the abdomen, and then they fall down in the testicular sac around the time that the babies are born. So sometimes they won't fall. They have testes, but they haven't fallen down into their testicular sac. So since the abdomen is warmer than the outside of the body, it can cause fertility problems because the sperm start to die because the abdomen is too warm. Sometimes kids that have undescended testes will also have an inguinal hernia. So the testes, they still secrete their normal hormones, so they don't have problems with sexual development, but they can have problems with infertility. So the name of the surgery they can do this is orchiopexy. So they will surgically pull the testes back in. And kids that are born with this are higher risk for testicular tumors as they go through childhood and adulthood. So after surgery, you're gonna, make sure that they understand, and you're like supporting where they've had the surgery. Just to be aware, it can be embarrassing if you're a boy to have surgery on your private parts, and make sure they know that the rest of their development is going to be normal, because their testes are still going to be, producing the hormones that they need. So always be, cognizant of the developmental age of your child. And, we've talked about this when we talked about Freud, that 3 to 6 year age, preschool going into school age, they start to explore their body. It's not uncommon for them to start to masturbate, and you just kind of have to prepare parents for that, to let them know. And then always be thinking about like an appropriate way to approach a child if they were to ever have to have surgery, always remembering those theories that we talked about at the beginning of class, their appropriate developmental age. So someone sent me a text message, a chat, asking about the handout for the exam 3. So it should be attached to the announcement that has the exam 3 review times. If you guys want to take a look while I pull up the next PowerPoint, but it should be on there.
It's not, it's on there, but it's not giving me access to like click on it or anything.
I was able to open it.
Yeah, I'm not able to open it.
Is that Chantel Moody that's not able to open it? Or who's not able to open it? Could you just tell me your name?
Chanel Arrington.
Chanel Arrington. Chanel, you've had all sorts of problems today. So Chanel, I'm sorry. Chanel, so I will, what I'll just do for both classes, I'll just email the PowerPoint to everyone. And so you have it on the announcement, and I'll email it to you.
Okay. Thank you.
You're welcome. Okay. Okay, so we're gonna look at the skin conditions here next. It's getting a little bit with the quiz, all the technical problems. We're probably gonna not be able to get to everything today, but I will do my best to highlight the most important aspects. I'll also, just for your reference, I'll post last year's lecture into the announcements. So if you have any interest in kind of going more in detail about skin and communicable diseases, you can also watch last year's lecture for week 8. So when kids have problems with their skin, nurses really need to be able to describe it well. Remember, when you're a nurse, documentation is key to everything. So thinking about the size and the color, is it painful? Does it itch? Where on the body is it? And using like your general medical knowledge to describe stuff accurately. So when kids have rashes or other skin problems, making sure that they don't itch too much is really important, because if they scratch their skin, then that can set up for infection. This one slide here kind of goes over some terms that you should know when you're describing problems with the skin. So like a macula is flat, this would be something that's a freckle. A papule is elevated. So this is like a pimple, but not a whitehead. And then a vesicle is a fluid filled, something you might see with chickenpox. Pustule is also fluid filled. It's like an acne. It's like it's a papule that has a whitehead. A scab is a scab. A wheal, you see this in allergic reactions. It's that hive, those raised bumps that don't have any fluid in there. And then ecchymosis is that black and blue bruising. So you should be able to recognize the different words and what they mean. So kids can develop a sty, which is an inflammation of the sebaceous gland right around their lower eyelid. So this is not uncommon. They usually start with like a warm compress to pull the pus out of the sty. And then if it doesn't work, then they'll end up giving them antibiotics. There's a couple different birthmarks that you need to be able to recognize. The first one is a strawberry nevus. So it's kind of like the strawberry colored. This one usually doesn't require any treatment, and you don't necessarily see it right at birth. It can happen a few weeks after birth. And like I said, it's usually not a problem. They usually don't need any treatment, which is different than a port wine nevus. And this one, it doesn't go away. And sometimes they do need treatment. It gets darker over time. And then cafe au lait spots are something that kids can be born with. They're kind of this light brown oval color. They are associated, if they have multiple cafe au lait spots, with neurofibromatosis and tuberous sclerosis. These are like genetic problems. And the tuberous sclerosis is also associated with these hypopigmented macules. So the tuberous sclerosis is this rare genetic disease that causes these benign tumors throughout the body. So you need to be aware they're normally not a problem unless they have several of these, but sometimes people will think it's child abuse, especially the cafe au lait, because they're kind of like a light brown color that could be, you know, concerning for like a purplish bruise. So you need to be aware of what they are and document them. And it can be something that they're just born with and there's no problem. It's not associated with any other problem, or they could be associated with these rare genetic conditions that will need follow-up. So this butterfly rash, you should always, whenever you hear butterfly rash, you should think about lupus. This is this characteristic rash across the bridge of the nose. Scaling skin eruption is not common. This is associated with zinc deficiency, and it's kind of like a rash around the mouth. It's kind of like a reddish color, and it's also on the cheeks. It's pretty specific to the zinc deficiency and in infancy, but you don't see it very often. It's not normal to have vitamin and mineral deficiencies in the United States. Sometimes if you have kids that have birthmarks around their mouth, then you need to be concerned about their airway. So this is something to be aware of. If you see a birthmark close to their mouth, they might need some additional imaging. And if they have in their lumbar region, so along their spinal column, then they might need additional imaging to see if there's a problem with their spine development. This is something that malaria that sometimes parents really worry about. It's like this heat rash. It's just like prickly little bumps that they get normally when they're hot. You can see it in between their skin folds or in their diaper area. It's just kind of getting the skin cooler, maybe taking off the excessive clothing, etc. It doesn't really need any other treatment. Itiligo is just skin chafing. So, you know, that rough, irritated skin, usually where you're going to have like skin folds or something like that. So you're going to see it more in obese children where they have more skin folds. So seborrheic dermatitis is just that cradle cap. So like this accumulation of skin from this sebaceous glands on their cap. A lot of times it worries parents because it's ugly. You normally see it in the infant, but it's not itchy. It doesn't bug the baby. It's just kind of ugly. So the main treatment is just to try to wash their hair. And then sometimes they have like a soft brush where they try to get that extra skin off. So diaper dermatitis is just a fancy word for diaper rash. If it gets like a beefy red, then you worry about candida, which is going to be like a yeast infection. So the best thing is to prevent it with frequent diaper changes. You might also kind of air their butt off after you do the diaper changes. And then if it develops the yeast infection, then they'll need specifically a cream that treats yeast. So acne vulgaris, this is just going to be the acne that you see in puberty, but it's the really big pimples that are kind of painful. They can also develop blackheads and whiteheads. So just, you know, a lot of good skin care, cleaning the skin. Sometimes they also need medications. They do produce a lot more oil when they go into puberty. So that kind of leads to it, and also their hormonal changes. So if they clean their face too much, it can lead to irritation. So like, you know, usually like a gentle wash. And then if they need it, there are both topical and oral treatments available. Kids can get, cold sores or fever blisters, which is actually like a herpes type 1. So this is going to be something that they treat with antivirals. And you guys are probably familiar with eczema. So infants can get eczema. So it's usually something that runs in the family. Usually kids that have allergies are more likely to have it. Usually is worse in the winter when the skin's drier and colder. You need to make sure that parents are kind of on top of it. Those eczema lesions are a setup for a bacterial or viral infection. And then they may flare up after immunizations. There are treatments that they do. So usually there's like creams that they can put on. They also recommend like a cornstarch bath or a baking soda bath. Your main thing is to prevent itching so they don't like scratch the skin where they can get an infection. They do use some corticosteroid screen, but that's really limited because it doesn't treat the underlying cause and then they're being exposed to steroids. But they might get anti-itch medications, and then if there's any concern for an infection, they would also get antibiotics. So it's best to give them the bath and then put the cream on. And you also want to wash the cream off before you put a new layer on. But it is best absorbed after they take a bath. You want to make sure that they're following directions, using the right amount of ointment. Sometimes they put elbow restraints on so the kids can't scratch the area. And then they don't normally do a lot of topical steroids, but sometimes they do. But it does kind of increase their risk of a viral infection. And it also just kind of exposes them prolongedly to steroids. You don't want to do that a lot throughout their lifetime. So newborns are obviously at risk because of their immature immune system. So we have staphylococcal bacteria on our skin. So places where you might see a staphylococcal infection of a newborn are going to be places like circumcision site or the umbilical site. So you need to make sure that parents know that if they see any of these small pustules, that they need to report that immediately. That could be a sign of a staphylococcal infection. And then there is MRSA out there in a lot of communities. So if a baby lives in a community where there's a higher rate of MRSA, then you need to be concerned that it could actually be MRSA. So, always keep a really close eye on your newborns. Report anything suspicious and kind of keep on the lookout for these small little pustules. So scalded skin syndrome is going to be caused also by Staph aureus, but it kind of gives this red look to the skin. It doesn't normally cause any scarring, and once the infection goes away, they tend to get better. Just to be one of those things, we always worry about child abuse in kids. So just to make sure it looks like it could be child abuse because it kind of looks like a burn, but it's really a bacterial infection on their skin. So impetigo is this highly contagious. You see this very often in like preschools, daycares. They kind of get them around their mouth a lot of the times. It's like a cluster of little red bumps with this honey crusty stuff on there. And it is very, very contagious, and you do need to treat it with antibiotics. It's one of those things that'll kind of go through a daycare center where every kid in the daycare center gets impetigo.
Professor.
Yeah.
It's actually really crazy because my friend literally just texted me that my godson has impetigo, and she sent me a picture. I don't know if you can see it, but it looks really bad though.
Yeah, it's not normally it's really treatable. But it can obviously lead to like a secondary infection because the skin is exposed, but it's ugly. But they do need to treat it. I'm glad you said something because it's super is your godson in daycare or anything like that?
No, but she has a newborn, so
Yeah. So. Oh no. Okay. Well, so hopefully, the kid's getting treated.
Yeah, she was telling me she just turned the prescription in and stuff, but I was like, that's crazy. I told her I was literally just learning about it right now.
Yeah. So, you know, in addition to the impetigo, which is the bacterial skin infection, kids can get fungal infections. This is going to be like your jock itch, your athlete's foot, etc. So these are usually treated with antifungal creams. And this one here, pediculosis, is just referring to lice. The most common is going to be your head lice, where they have to wash with a special shampoo and they have like a comb where they have to get the nits out. It's another thing that is highly, highly contagious. So it tends to run through families pretty quickly. And then scabies. So you're going to see scabies. If you see, they look like, they call them mite marks. So they're like little lines that run up, usually in between their fingers. It is a parasite, and they burrow under their legs and their skin. Could you guys hold on just 1 second? Bueno, I'm so sorry. Thank you for your patience. So when kids have scabies, it tends, another thing that's super contagious, it'll run through families. So it's spread by close personal contact. So, the kid will have it, can pass it to the parents and vice versa. You need to treat it with a specific cream, and everything needs to be treated, the house, the car, because the little parasites lay eggs, and it's very hard to kind of get rid of once it's in a house. So there is a lot of information on burns. Not all of it is stuff that you really need to know. So it is a leading cause of death between the ages of 1 and 4, and it can be a sign of child abuse and neglect. So it's one of those things, you got to be on the lookout always with kids, got to be thinking about child abuse. So, but it also can be just like the kids get up before the parents aren't really awake and they get into something. So, it's usually a thermal burn, but there's different things that can cause burns in kids, and chemical, electrical, radiation. Electrical, you're more likely to have problems with their heart. So you need to be paying attention to where the entry and exit of an electrical burn is. Something with burns, if there's anything around the face, you always have to be worried about airway management, thinking about if their airway was affected from the burn. So I know in adults, they talk about the rule of 9s. So kids don't have the same body proportion as adults. So this chart here just kind of gives you the percentage of body surface area based on their age. So they still talk about the rule of 9 in kids, but I just want to point out to you that kids, they're kind of short and squatty. They don't have the same body proportions as adults. So if you're ever really going to be estimating their percentage of their burn from their body surface area, and they're not like a teenager, it's best to pull out a chart that kind of shows you their distribution of their skin based on their age. So kids have thinner skin, so they can get burned more easily, they can scar more easily. They're a greater risk for fluid and electrolyte loss and heat loss. So they tend to suffer more from burns than adults. They also have a smaller muscle and fat content, so they need more protein recovering from a burn, because the protein and muscle that they have is more likely to be, damaged, because they don't have as much of it in comparison to adults. So when you have a burn, obviously your skin is like a barrier to preventing an infection. So when your skin is damaged, you're at an increased risk for infection. So always remember, like recovering from a burn, you're a much higher risk for infection. We kind of break down burns based on the amount of body that's burned and how thick the burn is. So a moderate is going to be partial thickness that's 5 to 30%, or full thickness that's less than 10%. So full thickness is going all the way through the skin layers. So just remembering that, it could be a small percentage, only 10%, but if that's full thickness, that's still a moderate burn. And then a major is partial thickness, that's 30%, or full thickness that's more than 10%. So it's an open wound, they're at risk for infection. You need to kind of cover it. Like if you're seeing them in an outpatient area, they normally go to a burn center. I'm going to skip ahead to the emergency care. So if you're dealing with it in the moment, get them away from what's burning them. You want to evaluate the injury, cover the injury, and then you need to get them to the hospital. You always want to be making sure you're paying attention to airway management. They can have sloughing of the airway, damage to the airway from inhalation of smoke. Also making sure you get an IV line placed. And they might need also like a nasogastric tube to help remove their stomach contents. Thinking about wound care, like I said, it's almost always in a hospital that's a little bit more of an advanced, like you wouldn't expect to really be doing complicated burns at a community hospital. But it's painful. They have to do skin debridement. They can be in the hospital for a long time. They need a lot of fluid replacement because they lose a lot of fluid to their damaged skin. Because of the damage to the skin, they're higher risk in an infection. So they're frequently in this protective isolation. You need to make sure you have all the instruments are sterile. You're going to be doing sterile gloves, sterile dressing changes. So they can get fluid overload because they do give a lot of fluid, and especially in the initial period. They have higher metabolic needs because of their damage to their fat and their protein. You need to try to, help them recover as much as possible, prevent contractures. It's obviously damaging psychologically to both the child and the parents. So that's the burn. You can also think about sunburns, making sure as a nurse you're doing anticipatory guidance and making sure they're talking about putting sunblock on, avoiding overexposure. And then on the opposite end of the spectrum, you can have children that have frostbite, where they have extreme cold that causes damage to their skin. So we don't have time to go over the communicable disease PowerPoint, but I emailed it to you. The things that I really want you to pay attention to in that PowerPoint are the different terms, and then the different types of isolation, like knowing the difference between like airborne. When would you guys use airborne? What type of patient needs airborne isolation? Do you know?
Like tuberculosis?
Tuberculosis. And then droplet, anytime they have like a respiratory infection where they're spitting or anything like that, they need droplet. And then contact is any sort of a wound or something that you could touch their body fluid. And then if not, they just need their standard precautions. So I know this is a lot of information for the week before your exam. Do you guys have any questions? So what I'm going to do, I'm going to email in case people are having a hard time opening the exam 3 PowerPoint. So this afternoon, I'll email you the exam 3 PowerPoint. I encourage everyone to go to one of the exam reviews. I will post the exam reviews and the announcements. And then for those of you that had technical problems, there was something going on with your quiz. I have 4 of you written down. Send me an email. I would like to try to get all of you in at one time to do the quiz. The worst case scenario is that I have you take your quiz after your exam next week, but I will make sure everyone that was here today takes their quiz without any deduction in points. Any questions? All right. Thank you for your
Yes,
patience.
I have a question.
Yeah.
So since we still have time, can we do the quiz now or do we have to wait for next week?
So I do not have time to do the quiz now. So is this SATA?
Yes.
SATA, I apologize. Your computer froze and I know that's why you weren't able to do it. Do you have time later this week to take the quiz?
Yes, I do. Tomorrow, Thursday and Friday, I'll be good.
Okay, just send me some times and I'll do it with you either on tomorrow, Thursday, or Friday. We'll get it done this week.
All right, thank you.
You're welcome. Anything else?
I would just prefer to take mine after the exam next week.
Okay, that is fine. So Denise, you're gonna have to arrange a time with me because of your problem that you had when it was started before you were really taking it. I don't have time to stay and give the quiz to anyone right now. So if you want to take it after your exam next week, just
It will be
send me a message so that I make a note and I'm not like trying to set up a time to take it later in the week. If you want to take it with your exam next week, that's fine. Just let me know. Are there any other questions? Okay, so have a good week, everyone. If you have any questions, please send me a message on Canvas and I'll get back to you. Otherwise, have a good week 8.
Oh wait, I'm sorry. You're gonna resend the exam study guide, right? Because I can't.
Yeah,
open it.
I'll email it to everyone. So it's attached to the announcement and I send it via email.
I think it's the
All right.
format of it. Like when you send it to Word, I can access it, but when it's like sent through like Firefox or something, I can't. Open
Okay.
it.
Okay, I'll send it as a PPTX and as a PowerPoint. That's the only 2 versions I have, and I'll email
Okay.
it to you. Okay?
Okay.
All righty.
Thank you.
You're welcome. You guys have a good day.